Thank you. So I have no disclosure. I would present you a case of a male patient of 59 years old who had undergone hemodialysis since 2001. He had multiple bilateral arteriovenous fistula and central venous catheter placement during his history until December 2017 when he received a renal transplantation. The last arteriovenous fistula created was a right brachiocephalic one, and he was treated with in March 2021 with a balloon angioplasty for a right central venous stenosis in another center. When he came to our attention in July 2021 for a recurrence of central venous stenosis symptoms, something like arm swelling, tenderness, and visible skin collateral pathway. So this is the fourth venogram and showed us two different stenoses, one at the level of the Flavian vein and the other one at the level of the brachiocephalic and SVC junction. So it was chosen to treat it with a single bare metal stent covering both stenosis and avoiding the closure of the internal jugular vein. And this is the video of the procedure. No, look, okay. This is the procedure with a nicely deployed wall stent, but probably due to an oversizing of the stent, during the post-dilatation, there was a dramatic shortening of the stent, and it was chosen to extend distally the stent with another wall stent inside of the first one, with a nice final result. But less than 1 year later, in May 2022, he came to our attention again for arm swelling and shoulder pain, very localized just behind the costoclavicular joint. The ultrasound showed us a patent subclavian vein with an intrastent flow acceleration. These findings were confirmed by the CT angio that showed us also pleural effusion, some infected hepatic cysts, but also at the level of the stent graft, at the stent, some grade of restenosis, and the terminal part of the stent seemed to be outside of the vessel. So we decided to bring the patient to the cath lab and try to do a stent realignment procedure. But it was impossible to pass through the handle of the stent without wire, and it was confirmed by the phlebography. And even when we tried to dilate the stent mesh and pass an 8-French sheet, it was stuck into the struts of the stent. So what to do in this case? What we did is another brachial access, venous access, and a rendezvous at the level of the arm, and when we got the wire through, simply pull down and try to get in the stent with another wire coming from the brachial, but simply didn't work. So another weird idea came to our mind, do something like a lasso with a snare and a thermo wire coming from below and pull to have a fracture of the stent in order to pass through the hole. And what happened is that alveoli struts of the stent broke apart, and this was the result. At this stage, we were a bit afraid of venous perforation, but we could easily manage to pass a 12 French sheet and deploy a rhapsody stent graft just very close to the cephalic arch. But again, we were a bit afraid of stent dislocation because of the arm movements of the patient. So we decided to anchor the stent with another bare metal stent just proximal to the stent graft with this final result. And this was the ultrasound control after the procedure, showing us a very well deployed stent and a cephalic arch patent with a bit of turbulence at the level of the cephalic arch. And this is the picture that I took of the patient that I took some days ago that showed us that perfectly normal right arm, pretty similar to the other one, and a patent cephalic arch. Concluding, central venous stenosis are Achilles heel of vascular access management in hemodialysis patients. Evidences are not definitive, but are suggesting us that stent grafts work better than bare metal stent. And sometimes we have to think out of the box to succeed in this procedure. And we have to consider at the last that patient is not a tree, he moves his arms, so it should be considered during the deployment of the stent. Thank you.